All right. Hello, everybody. Welcome to the Innovation Premium, how healthcare plans are responding to the high cost of advancements in medical technologies. We're glad you could join us today. We're just going to give another minute for some people to get on from the waiting room, and then we're going to start. Just want to mention a few housekeeping things before we begin. First, we have a Q&A feature. So if you have a question during the presentation, or a comment, you can put it in there and we'll get to it when we have an opportunity to respond to it. And otherwise, the chat feature is going to be disabled. So if you have any particular problems, you could message me directly, and we'll go from there. And to just get us started, first of all, just everyone, welcome to our talk. We hope that you get something out of being here today. We looked at what people were talking about in terms of healthcare costs and access, as well as potentials for reform. And John and Kent put some stuff together to talk about that today. So what I'm going to do is just briefly introduce our speakers today. First of all, I should say I'm Sean DiGiovanna. I'm the head of research for Gettysburg Healthcare Consulting, and I'll be moderating today. And I would like to introduce John Warren, who is our principal at Gettysburg Healthcare Consulting. He's a former official at the Centers for Medicare and Medicaid Services. He's gone on to have a successful career in healthcare consulting. He leverages deep understanding of the federal healthcare financial process, including coverage, coding, and reimbursement. And we also have Kent McKinney here with us. He has over 30 years of leading Fortune 500 companies through federal healthcare payment reform, product commercialization, and market access. Kent works with Gettysburg to help clients gain and maintain market access for their products. He's also an adjunct professor at the Joseph L. Mailman School of Public Health at Columbia University. So great speakers today, and I hope you get a chance to really enjoy it. So what we're going to do is talk a little bit about procedure. Kent, if you can advance the slide. Actually, it's not in presentation mode if you want to put it in presentation mode as well. There we go. So just a disclaimer to start, as we usually do, this is intended for informational and educational purposes. It's not constitute legal, financial, or regulatory advice. So if you make any decisions based on this, please don't sue us. But we do think you'll find some interesting things in here. Kent, you want to advance the slide? So just a little bit about us that I talked about us before, but here's some our policy stuff. And also I should mention that this presentation will be sent to you as we after we do the presentation. So you'll get a copy of the slide deck as well. Okay, next slide is just going to talk about the agenda for today, right? So first we're going to start with some key takeaways. Kent is going to share those with us, and then he's going to go into a in-depth discussion of how the market for healthcare plans and costs work, and how that is affecting access and affordability. And then he's going to turn it over to John, who's going to talk about attempts at pricing reform, particularly about through Medicare, CMS, and the actions they're taking to try and control costs and increase access. And then we're going to wrap up with just some questions and answers for you guys to have your say, and also to ask anything that is on your minds. So as I mentioned before, throughout the presentation, you can use the Q&A feature. And if you have comments or questions, we'll deal with them either as they arise or at the end. And please message me if you have any technical difficulties. And now I'm going to turn it over to Ken. Ken, you're on mute.
Sorry. Thanks, John. It's great to see so many familiar names and faces on the call today. So thank you for joining us today. And what I wanted to start off with was a discussion of some of the key takeaways that, as a team, when we put the slide deck together, we hope that you'll have a better appreciation of as we move through the content in the deck. And so the first key takeaway is that patient access and affordability to healthcare is quickly becoming a public health issue, if not a crisis. It's really access and affordability is really reaching a critical point in the U.S. healthcare system. And it's probably worth noting that what I'm referring to with access and affordability is patients that have good health insurance, not patients that can't get health insurance or they're uninsured. That clearly is a public health issue as well. But what I really want to focus on are market forces that are impacting access and affordability for patients that have really good health insurance. Um, I want to tee up some ways that the healthcare system can think about addressing these issues by creating win-win situations where patients win, health plans win, and manufacturers win, as opposed to current state where health plans are generally, they scrutinize new products and innovation entering into the marketplace, and they generally will either over PA a product as an example, or make a non-coverage decision, or place the product on a higher copay tier or assign co-insurance to it. And those in the aggregate, all those different cost mechanisms are decreasing the access and affordability for patients that are signed up into the plan. And so we'll talk a little bit about how to keep innovation rewarded, keeping these new treatments and cures coming out into the marketplace, and creating win-win situations for everyone. And one of the last key takeaways is that if left unaddressed, I think that it's clear to say that the government is only just starting its foray into pricing with the direct negotiations out of the IRA. If we don't continue to address, or if we don't start to address affordability and accessibility, then the IRA negotiations will, I think, be the first kind of shot across the bow. And John will talk to you a little bit about where the Medicare program and CMS is at right now with pricing. So I'm hoping that we can come up, because I mean, honestly, I'm a key proponent of innovation. I think innovations should be strongly rewarded. All the studies point to the fact that societies do better when there's more innovation to treat diseases and to prolong life. It's just that we need to try to figure out how in a marketplace where everyone is kind of interrelated, how pricing decisions can be used to help improve patient outcomes. So let's first look at innovation and rising healthcare costs and the interdependencies between those two. Um, Healthcare is purchased in a marketplace, and it's not too different of a marketplace than where we would go to otherwise shop for other consumer goods and services, like cars or other things. Um, there are consumers that every year in open enrollment go to the marketplace to search for a health plan based upon their own unique needs and their family's needs. And they will look for things like cost sharing, premiums, is my drug on formulary? And that creates a tremendous amount of competition in the marketplace among all the different plans who are offering health benefits, either medical and pharmacy benefits, at different price points and different premium levels and different deductibles. And then also rounding out the health insurance marketplace are the manufacturers, the suppliers that manufacture goods and services to be sold, in this case, through the health plans to the consumers in the health insurance marketplace. I want to convey on this particular slide that changes among any of the three key players in the healthcare marketplace have an impact on each other. Whether it's a new drug coming out from a manufacturer and how the health plan thinks about how they're going to cover that new drug. If the patient is complaining that they can't get access to the drug, then that really would have a dampening effect, I think, on competition, where health plans need to be more competitive in this marketplace to attract patients. So I hope that you have an appreciation of how all of these three different segments work together, and it's really a zero-sum game. Different changes in manufacturing or what the health plan offers is going to impact the patients and everyone else within this marketplace. I'll give you an example. So if we have a manufacturer that is coming to the market with a new 80,000, let's say arbitrarily $80,000 drug that they want to sell into Medicare and commercial health plans. Health plans will, do what they need to do with that drug, including P&T and reviewing the clinical effectiveness of the drug and other things, decide where they put it on formulary if it's an oral outpatient drug, and assign cost sharing to the drug. So it may not be readily apparent when we think about new drugs entering into a marketplace, but those new drugs on the other side get pushed out. A part of that $80,000 in this example gets pushed out to the patient in the way of copay, cost sharing, which will generally increase or decrease at the beginning of the plan year based upon what each one of those different health plans is going to do with the product. So the patient does feel the pricing policies for the manufacturer, the medical device companies, products that they sell into this marketplace. It's not a situation where the health plans absorb 100% of that cost, that sticker price, and the patients go along, their merry way. They actually are sustaining a tremendous amount now of the increasing costs that are coming into the marketplace. So I wanted to make sure that we level set, how the system works, particularly pricing sensitivity, competition, and other market-based forces. So how this is playing out in the marketplace is that, yeah, I read this article and I think it was quite timely. It just came out maybe a month or so ago out of the Kaiser Health News. And they looked at the cost, the healthcare cost associated with cost sharing. And these were for health plan members. Again, these were members that had really good health insurance. These were through the ACA marketplaces, the state-based health insurance marketplaces, where individuals, not individuals that work for large companies, but individuals who may work for themselves, go into these marketplaces and buy health plans every year for themselves and their families. Those premiums have jumped on average 26%. And I think the article reflects that it's due to that increase in premium is due to higher hospital costs. And they call out the price of new GLP-1 obesity and diabetes drugs. It's very similar, in fact, to that chart or the slide that I showed you, just the slide before this one. This kind of brings that point home. And where that really becomes a public health issue is that 40%, 4 out of 10 adults that were interviewed as part of the story said that they were planning on skipping or postponing necessary care because of the cost. Not the sticker price, but what they mean when they're saying cost is cost sharing. Whether it's high deduct, I just went to like last open enrollment to buy insurance, and there were health plans that had a $12,000 deductible. And so, what we're seeing here with the market forces that are entering into the marketplace is behavior from the health plan where things like deductibles that are getting pushed off onto patients are creating this really severe inflection point on access and affordability. And so what are the factors that are impacting access and affordability and the rising cost of health plans and cost sharing? Well, it's the information that's in this slide. It's gross domestic national healthcare expenditures over time. Okay. As Sean mentioned, I do teach a lot of these concepts to graduate students, and I looked at my first lecture 14 years ago, actually 15 years ago, and in that lecture we had $2.5 trillion of gross domestic healthcare spending, nominal spending. And in a very short 14 to 15 years, we're now almost eclipsing $5 trillion in domestic healthcare spending. Now, what concerns me is the slope of that curve over the last 15 years. And one quickly imagines where we'll be in the next 10 years. So if cost sharing, 4 out of 10 patients are foregoing medical services, possibly drug therapies, mammography, screening tests, things of that nature, because of what you see on this slide, in the next 10 years, I can only imagine that will the government enter more forcefully than it already has with direct price negotiation. And that's I think a very realistic question that we need to think about. Um, why has healthcare cost and these cost sharing within health plans expanded over time or gotten higher over time? I think it's a function of the innovation in the marketplace over time. And so for thousands of years, there really the only health technology was maybe a dressing, cleaning a wound out and changing a dressing and trying to keep that wound sterile to prevent infection. And for thousands of years, that was the kind of the hallmark of healthcare technology. And then in 1928, Dr. Alexander Fleming discovered penicillin. And since that time, in that 100 years, um, we've seen the we've seen all the healthcare technology that we experience today really blossom over the last 100 years. Things from where we went from penicillin back in 1928, we now have heart transplantation. We have molecular diagnostic testing. We have drugs that cure diseases, not just treat the symptoms. We have CAR T therapies. Um, and so we have come a tremendous amount from 1928 to where we are today. And, society wants this new innovation. They want treatments, they want cures, but the 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 cost, the slope of the last 100 years of that line is directly proportional to that domestic healthcare spending. So we want more innovation as a society, but it comes at a premium, an innovation premium. And we'll talk more in detail about the innovation premium. So just for a moment, consider yourself a health plan manager. You're trying to manage the P&L for your health plan, and you're trying to manage and create pharmacy and medical benefits for health plan members that are substantive, that reflect the newest treatments that are out there. You want to offer that to your patients. Drugs like aducanumab or treatments for Alzheimer's dementia. Sovaldi, if you recall, several years ago, Sovaldi came out as a treatment for hepatitis C. Drugs like Luxturna for partial blindness. But you would love to have those, but they come with a very expensive price tag in relative terms. So health plan managers and health plans in general have to think about how they're going to cover a new drug when it comes into the marketplace. Let's do a double click through now in aducanumab to exemplify this point. Aducanumab was approved in June of 2021 as a treatment, not as a treatment for Alzheimer's disease. It actually will reverse beta amyloid plaque in the brain. At least some of the clinical trials alluded or pointed to that fact. So you're not treating the symptoms, you're actually reducing the progression, or at least holding the progression at mild cognitive impairment, which, by the way, is the indication where patients have to have, exemplify mild cognitive behavior to be able to be put on this product. It originally, from Biogen, entered the market at a $56,000 price tag. And subsequently, the company lowered it to $26,000 a year. So there's estimated 12 monthly treatment cycles. It's physician administered. There are diagnostic tests that have to be provided. So those are generally so I'm looking at the economics of the whole situation here. Those are generally about $700 a piece. And consider the fact that if you're a health plan manager, maybe you're in Medicare Advantage or you're working some way in fee-for-service Medicare, there are 6 million Alzheimer's disease beneficiaries. 2 million are eligible to receive aducanumab, or in other words, they have mild cognitive impairment. Now, if only half of the 2 million actually were placed on the drug, then you would see cost in excess of $28 billion to the Medicare program. And so just to give you kind of a relativity of where that drug spending would place aducanumab, it would eclipse drug spending on the top 10 physician administered drugs in the Medicare Part B program. And so that's a lot of things to think about on the economic side. I mean, obviously, you love the innovation itself, but realistically, you have to look at, and I know that CMS looked at and created a national coverage determination for aducanumab, which diminished and greatly slowed the actual utilization of this product to the extent that the manufacturer discontinued the product from the marketplace. So clearly not the best launch scenario for a drug. And if you think about, what as a society we get for all of our healthcare spending, as a country, the U.S., when compared to other industrialized countries, is an outlier. Not only do we lead the world in domestic healthcare spending, we would be considered an outlier when you compare us to other industrialized countries. Um, to the extent where we're spending, I showed you that slide before, we're nearing $5 trillion of domestic healthcare spending. That equals about $12,500 per capita for everyone living in the United States. And so we as a country spend the most on healthcare, but what do we get for that healthcare expenditure? This is a relative way showing relativity across two components. The actual life expectancy of countries in the G7, including the United States, and what that life expectancy might look like or be predicted to look like based upon how that country spends or how much domestic healthcare spending that country currently spends on healthcare. And so you start to see kind of this perverse relationship, right? You would assume that the more spending that you have, the better life expectancy you would have in that country, but we're not seeing that. Japan should have a life expectancy above 82 years or somewhere around 82 years of age based upon what they spend domestically on healthcare. And if you go across this slide, you see there's the United States. Our life expectancy should be much higher based upon what we're spending, when in fact it is in fact very very much lower in this country based upon comparing it to domestic healthcare spending and life expectancy across the other countries. And so there's something going on here. We're spending the most in healthcare. We're getting the worst outcomes imaginable. I'll show you a real quick comparison again. Cardiovascular disease mortality rates per 100,000. I pulled this data off of the World Health Organization. Again, in the United States, we have a cardiovascular mortality rate of just under 200 per 100,000. Okay. And if you look at a similar cardiovascular mortality rate, Guatemala is a great example. They spend about $38 per capita on healthcare in Guatemala, while we spend $12,500 per capita in this country. And we get the same cardiovascular mortality rate. If you compare us to Spain, who spends a third or a quarter of what we spend on healthcare, then you see they even get a lower cardiovascular disease mortality rate, and they're spending much less than we are. So we can't continue to think about the more we spend, the better health outcomes we're going to get, because that is not at all the relationship that I'm seeing with the domestic healthcare spending in the United States. So before I turn it over to John, I just wanted to share with you how a health plan thinks about all these different marketplace dynamics and running their own business, their own health plans. And they do that through a lens called a medical loss ratio. The medical loss ratio consists of, in the numerator, claims costs that go out the door to pay the bills, to pay providers, hospitals, doctors, to pay for drugs, to pay for medical devices, to pay for new innovations that are coming into the marketplace. The denominator of the medical loss ratio is the premium revenue that they have established at the beginning of the plan year, and they play that through the whole year. So that, the denominator is that premium revenue. So you can see that an MLR greater than 1 or 100%, you have a numerator issue because you've got claims costs that are outpacing the revenue, which is the premium source of income to the health plan. So what happens generally is cost minimization by the health plan. We're not going to cover that expensive drug that's coming into the marketplace. We can't raise premiums because there's a competition factor there with other health plans that aren't raising premiums. So we're gonna jettison new drugs that are medical devices that are coming in, or we're going to over PA them, or we're going to negotiate hard with hospitals and doctors to get our medical loss ratio down closer to 1 or less than 1. I wanted to share this with you because this is the dynamic of what's going on behind the health plans. They need to manage costs over revenue. They often do it now by jettisoning expensive innovation. I have an alternative to this particular way of thinking about it. We'll get to that at the very end, so that innovation is rewarded, and that premiums don't necessarily have to go up. Cost sharing can go down actually, and still get health plans under a medical loss ratio of 1. But I'll say that for the very end. I'll now turn it over to John to talk about Medicare and some of the things that they're thinking about.
All right, thanks, Ken. I think Kent puts forth a very solid argument that growth in spending for healthcare has and continues to grow at a pace that's just simply unsustainable. And I think any policymaker or really any legislator would agree. The question becomes what's happening and what can Medicare do and what can the government and what should the government do to help control that? Well, we know that drug spending is a significant portion of overall health spending, particularly in the Medicare space. And we all know that the government and Medicare in particular are trying to invent and kind of experiment with different ways to manage overall Medicare drug spending. And some of those efforts, and we've heard about the GLOBE, the GLOBE model and the GUARD model, and we've heard about most favored nations, and we've heard about price negotiation and inflation rebates, and all of these sort of policies that are circling around Medicare drug payment. But we don't really a lot of times think about what's the pull through on the implementation of some of these policies, and are they having sort of unintended consequences? One of those unintended consequences that we've identified, and I think others have as well, is that all of this change is injecting a level of volatility and unpredictability into the Medicare drug pricing space, excuse me. It used to be where ASP for a drug manufacturer was relatively predictable. A manufacturer, particularly of a brand name drug, understood what it sold its product for and how much of its product it sold. So it could relatively safely predict what its ASP is now, and through their various forecasting tools, what it's likely to be in the future. Now, what's happening is with all of these different tools potentially affecting ASP and affecting it in different ways, I think drug makers are faced with an environment where there is a lot of unpredictability in sort of pricing for drugs. And as a result, some of the modeling and some of the forecasting that these companies do has to become more and more sophisticated as time goes on. I think historically, though, there was also sort of a belief that from a drug maker's perspective, their margins were safe. They knew what ASP was going to be, at least from the Medicare side. And they knew that commercial plans would oftentimes anchor their own rates to Medicare rates. So again, their modeling and their predictive abilities were relatively safely able to determine what a company's margin would be in any given time period. But all of these price reforms that we're talking about, whether it's most favored nations, whether it's negotiated pricing, whether it's Globe or Guard or whatever, are having the impact of compressing those margins for manufacturers and forcing manufacturers to think of new and unique ways to, manage their portfolios and their pipelines and their market access activities in a way to address or at least consider some of the volatility that's in the market. And we're seeing that, I think, a little bit in terms of site of service changes. It used to be that site of service wasn't that important or a highly critical issue, particularly to CMS. There's always sort of been a discussion about site of service shifting and different payment rates and different sites of services. But I think as we continue to see more volatility, more unpredictability in the government pricing space, we're going to see providers looking for less expensive, less costly ways to provide care. And that could mean an added increase, an additional increase in migrating patients to lesser cost sites of care, whether that's an inpatient facility to an outpatient facility, an outpatient to an ASC facility, or what have you. I think we're going to see more of that shifting in site of care, particularly, as Kent alluded to earlier, particularly as insurers themselves are looking for ways to better manage their overall cost structure. So if you go on to the next slide, Kent. And really what that means to a manufacturer, I think, is when a manufacturer thinks about channel strategy, they really need to incorporate into that a robust discussion of particularly government reimbursement, right? Because there are all of these policy pressures, that we've outlined that are having an impact on the price at which Medicare and ultimately commercial payers are willing to reimburse for a new drug, and in a lot of cases for an existing drug. Those policy pressures translate into an impact on the providers themselves. The providers are looking to see, how can I stay in business, quite frankly? How can I continue to provide the care that my patients need in a scenario or in a situation where reimbursement is less than clear and is variable from year to year, and in some cases, significantly variable from year to year. Some of that may pull through to changes in sites of care, like we talked about. We're seeing, we've always seen changes from outpatient to ASC. We're also seeing more and more increase in point of care testing in the diagnostic space in an effort to reduce some of the cost and some of the spending on diagnostic testing. And really, this is pulling through to utilization, right? All of these things together have an impact and tie back to the utilization of healthcare services and the attempt and the need to figure out, to determine a way that providers themselves and insurers are able to allow beneficiaries and their patients to have access to the right care for the right person, of course, at the right time, and then layered on top of that at the right price in a market that is continuing to shift. So those inflation, and I want to take a second and kind of look at inflation rebates specifically as kind of a case study for what I was just talking about. So we've had inflation rebates in place for a couple of years now, where when a drug company or if a drug company increases their sales prices greater than the rate of inflation, they owe to the government a rebate of a portion of that excess increase. What's happening essentially here is those rebates are creating an additional liability for those manufacturers. They not only have to recognize that they may have to pay these rebates over time, but they also have to make sure that they build that into their overall cost structure and their cost strategy going forward. And that's because small moves compound over time, right? So as rates increase year over year over year, a lot of companies are finding themselves potentially facing the need to pay some of these rebates. And that really connects together, I think, a lot of the payment tools and payment processes that are in place, because it used to be, I think, that manufacturers could set a strategy and forget about it. we'll take a 3-point increase or we'll take a 5-point increase or whatever it is every year. And they'll just set that in place for the next 5, 10, 15 years, what have you, and really forget about it until, generics come into the market and they need to rethink that. Well, now with all of this variation that's in place, particularly with inflation rebates like we're talking about, Medicare is really forcing manufacturers to look closely at their long-term pricing strategies. And I think that's what Medicare is intending to do. I think Medicare is intending to use these price setting tools as a way to control growth in spending. Kent, if we can go to the next slide. And really, we say here how Medicare is anchoring the drug price equation. We've known this. What's interesting here is, I just read an article earlier today, or an editorial, I should say, from the New Jersey Biotech Association that sort of talked about innovation in drugs, in the drug space, and the unintended consequences of government price setting. And, the U.S. is a leader in innovation in terms of new drug development and so on. And that comes at a cost. And there's some concern, some real concern, I think, out there that a GLOBE or a GUARD or a most favored nations model could have the unintended effect of squelching to a degree competition in terms of developing new drugs within the U.S. In fact, we've seen increases in Chinese clinical studies. The Chinese have continued to grow in terms of innovating new drugs and innovating new technologies. And I think, the government needs to be aware that while they are sort of currently driving some of this drug price discussion, that not only on the behalf of manufacturers is it critical to think ahead, but I think the government needs to think ahead as well in terms of what are the unintended consequences of forcing prices down through administrative cost setting. So if we go on to the next slide, Kent. So really, where is this leading CMS? So CMS has become, I think, more now than ever, a market shaper. They are becoming more and more disciplined in terms of how they are pricing products. They are looking to the market to help them make their decisions, but they're trying to make those decisions in as budget neutral of a way as possible. In a lot of fee schedules, like the ASP fee schedule or the clinical lab fee schedule, budget neutrality is not really a specific concept there, but they still have discussions about overall spending on drugs. We see it in the papers all the time, or even about diagnostics. We see articles all the time about review of high cost diagnostics, right? So certainly some of that is being driven by spending and is being driven by overall budget impact. And I think what CMS is trying to do with all of this not only is to drive down the pricing, but really to increase the value to Medicare beneficiaries. In other words, is the care that a Medicare beneficiary receiving from their provider appropriate? Is it the right care for their service? One of the things that CMS has always talked about is getting the right care to the right person at the right time. And again, now we layer on top of that at the right price. And CMS does have administrative levers that they can use to do these market shaping kind of activities. We know that ASP primarily is an administrative tool. We know that the clinical lab fee schedule, even though it's driven by statute like everything that Medicare does, has lots of administrative levers built into it in order to manage the expectations of those pricings. And CMS is trying to use those administrative levers. But in some cases, like the GLOBE and the GUARD model, the administrative levers just don't exist. And CMS is using its innovation center to experiment and to test out some of these new models to see how and where they have impacts on pricing. So I'm going to the next slide. And then for a pharma company too, and I've mentioned this before, and it's just a little bit of a summary, pharma's got to be actively involved in managing the economics of its products. And by that, I mean its launch strategy really has to take into consideration, I should say, all of these policies that we've talked about, from pricing changes to are we going to be subject to price negotiation, what's the status of Globe and Guard and most favored nations. All of that has to be built into a company's overall pricing strategy. And all of that needs to be layered on top of the evidence. So clinical evidence is going to be the foundation always of Medicare coverage for any service. Any service has got to be proven to be clinically appropriate for a patient. But again, and I sound like a little bit of a broken record again, but we're layering on top of that some of these price stresses. And then, it's important to monitor all of these signals as a pharma company. Where is the government going in terms of administrative price setting? Where are they going in terms of ASP? If you're a diagnostic company, where are they going in terms of the clinical lab fee schedule and PAMA changes? Are there going to be changes to the way CMS calculates prices in the future for whatever your service is? There are signals that come out of CMS, on a routine basis that can help to identify some of these things. So it's really important to be active in this process, as I said. Okay, Ken?
Okay. Thanks, John. So in closing, and I do want to leave a lot of time for any questions and answers that are out there, and afford people the opportunity to ask questions. So this is back to the way that health plans think about their business with the medical loss ratio. And if the original and the current way that medical loss ratio is managed is costs over premium revenue. And the current way that new innovation is not rewarded under this particular scenario is that cost minimization generally occurs to lower the numerator, or non-coverage decisions for drugs and new innovations, and that they're not covered, and that does nothing to motivate manufacturers to receive a return on their investment for the new innovation that comes into the marketplace. So what I like to think about is slightly redirecting the medical loss ratio by taking out a unit of cost in the numerator and putting in a unit of value. And by that, I think, what I would like to suggest is we need more drugs. We need more medical devices. We need new innovations that can be used to lower unnecessary health resources utilization, such as hospitalization or emergency room utilization, those really expensive settings of care. If you can have more drugs and more medical devices and more molecular diagnostic testing out there that will help you as an investment in those areas, lower the numerator for the medical loss ratio, then we can also address lower costs by eliminating unnecessary hospitalization. And if you think back to one of the original slides, we spend the most and we get the least on healthcare in the United States. I think there is something to be said, and I think part of that is because of unnecessary hospitalization. If we could just eliminate all the unnecessary hospitalization out there with investing in new technologies and new innovation, then medical health plans, I think, would lower their medical loss ratios below 1, and patients would, without question, I think their health outcomes would go up, innovation would remain strong, and health plans would continue to manage their medical loss ratios down at a sustainable rate. So I will turn it back over to Sean now for Q&A.
Well, I don't know, John, if you had any comment on that redefinition of the medical loss ratio.
I think Kent, your point is great, and sort of to put that, it's kind of in the Medicare perspective, right? Medicare, at least traditional fee-for-service, doesn't really think of a medical loss ratio in this same sense, because their drivers are different than sort of a commercial or an MA plan. But one of the things that's always frustrated me, and this ties directly into this, is when you talk to Medicare, and even when I was at the agency, Medicare is a very siloed organization, right? And there's really little opportunity to look at, for instance, an $80,000 drug that cures hepatitis C what are the downstream cost savings from that? We prevent a lifetime of treatment on other agents. We prevent, liver transplant. We prevent all of the other comorbidities that come along with hepatitis C by making that upfront expense of that $80,000 for the drug to cure the disease. If the agency were allowed to sort of think more globally and more holistically about its overall cost structure and where do we save money and what are pull-throughs on these, I think we get to a similar place in government spending, Kent, as you're advocating for in a commercial environment. So I really do, that really resonates with me, Kent. Thank you.
Thank you.
All right, and I'd like to thank both John and Kent for their comments today. And we did go a bit over what we predicted, so we don't have a lot of time for questions, but any that were put in the chat we'll be sure to answer remotely. I do want to call your attention to the fact that we do have some future webinars coming up. The next topic will be an analysis of the new technology add-on payments through CMS, also a review of a physician fee schedule changes, and demystifying the coding process. All those later on in the year, and there'll be a link in the presentation we'll send to you to subscribe to those. So again, thank you, John and Kent, for an informative discussion. Thank you to all of you for participating and for being here. And please check us out and look forward to our next webinar. And thanks, everybody.